us on a podcast platform and would like to earn ASHA CEUs, please complete all modules of this episode on your Speech Therapy PD account. You are welcome to put answers to put questions in the chat box, and we will answer those questions at the end of the episode. And here are the disclosures. I am the host of Keys for SLPs and receive compensation from Speech Therapy PD. Megan Whelan receives financial compensation from Speech Therapy PD for co-hosting this episode. Dr. Koch has authored a textbook, Clinical Management of Speech Sound Disorders, a Case-Based Approach. She also co-authored therapy material for Bjorm Speech Production. Carol Koch serves on ASHA SIG 10 and on ASHA 2025 Topic Committee and on the ASHA 2025 Topic Committee Chair for Speech Sound Disorders in Children. Dr. Kummer has authored a book, Cleft Palate and Craniofacial Conditions, a comprehensive guide to clinical management, and developed a clinical device, oral and nasal listener, ONL, and receives royalties.
And now let's meet our guests, Dr. Kummer and Dr. Koch. Dr. Carol Koch, ASHA Fellow CCC-SLP, is a professor and director of curriculum at Oklahoma Baptist University. Much of her clinical work has been in early intervention with a focus on children with autism spectrum disorder and children with severe speech sound disorders, including childhood apraxia of speech. Her research and teaching interests have also encompassed early phonological development, speech sound disorders, and CAS. She has been honored by ASHA Fellow and is a board-certified specialist in child language. Dr. Koch is currently working on the second edition of her textbook, Clinical Management of Speech Sound Disorders, a Case-Based Approach. She is also a co-author of the Contrast Cues for Speech and Literacy, the box of sets of cues for articulation therapy, multisyllabic words, prevocalic and vocalic R in the R inventory and facilitating context through Bjorm Speech publications. Dr. Ann Kummer, PhD, MAT, CCC-SLP, ASHA Honor, the organization's highest recognition, retired after 44 years of distinguished service as Senior Director of the Division of Speech-Language Pathology at Cincinnati Children's and as a Professor of Clinical Pediatrics and Otolaryngology at the University of Cincinnati College of Medicine. She currently holds the title of Professor Emeritus at UCCOM. Dr. Kummer has contributed extensively to the field with over 70 peer-reviewed articles, 31 book chapters, 4 authoritative books, including the widely used Cleft Palate and Craniofacial Conditions, a comprehensive guide to clinical management, 4th edition, which features an accompanying online graduate-level course with over 300 instructional videos. She also co-developed and simplified the nasometric assessment procedures, SNAP tests, and created the SNAP-R integrated into the Pentax medical nasometer. Dr. Kummer has developed more than 300 national and 100 international lectures and seminars on cleft palate, velopharyngeal insufficiency, and craniofacial anomalies, and she's taught graduate-level craniofacial courses at 5 universities. Welcome, Dr. Kummer and Dr. Koch. We're so excited to get to know a little bit more of you and learn about your career, research, contributions to our field, and perspectives on future.
Thank you, Megan.
Thank you.
All right, well, we are so happy to have both of you, and we're going to start off with a little bit of fun. Just for fun, can you tell us something about yourself that people may not know? And Dr. Koch, can you go first this time?
Sure. I think the thing that comes to mind first is that I am actually an advanced certified scuba diver. I have been scuba diving down to a depth of about 160 feet down in the Keys. So that's the adventurous side of me, I suppose, but it's a lot of fun and I enjoy it a whole lot.
Wow, that is wonderful. And Dr. Kummer, how about you?
Well, I'm not that interesting, but I will tell you that I met my husband in the 7th grade. He asked me to go study then. I said no because I liked his best friend better. He didn't speak to me for many years, but we both were at the junior prom with different dates, but we were both on the court together. And right after that, we started dating. And 4 years later, we got married.
Wow, that is a fun little tidbit. Well, thank you, both of you.
That's super fun. Okay, Dr. Kummer, I'm going to have you go first. Can you share a little bit about your journey? What led you to speech pathology, your earlier career, and why you chose your area of interest? So this is kind of a three-parter.
Okay. All right. Well, actually, I didn't plan to be a speech pathologist. When I was a little girl, I always wanted to be a doctor like my dad. My dad was an ENT, and I worked in his office on Saturdays when I was in high school, and then when I was in college during the summers. And I just loved what he did. I admired him. That's what I was going to do, either that or be a pediatrician. But as I said, I met my husband very early. And after college, he wanted to go to law school and I wanted to go to medical school, and that wasn't going to work. So I thought about it a while, and my dad suggested speech pathology. So I looked into that, decided that's what I was going to major in. But I was in the middle of my sophomore year, and I found out that speech pathology is not a 4-year degree. I went to Indiana University, and it was 6 years. That included the master's. So I ended up finishing the 6 years in 4 years and a summer, and was able to get my master's. Then we got married. And then I worked in the public schools in North Carolina, where my husband was doing law school. He was at Wake Forest. And I worked in the public schools for 3 years. And it really wasn't for me because I really liked the medical aspect of speech pathology. So when he graduated, we went back to the Cincinnati area where we had grown up, and I got my job at Cincinnati Children's. And when I think it was the second or the third year that I was there, I was put on the craniofacial team. And I just loved that. I love the population. I love the medical aspects of that. The other thing is that I was promoted to the coordinator and then the director and then the senior director of speech language pathology at Cincinnati Children's. And I love the business aspect and the leadership aspect. So I was 32 years old, and I decided it was time for me to go back to school. So I thought about going to school and getting an MBA or an MHA. And I didn't think that that was really going to be right for me. And then I thought about, of course, going to medical school, but I decided I'd be a terrible surgeon. After watching surgery, I thought, oh my God, I'd be terrible at this. And pediatrician, I thought that might be too routine. So I decided to get a PhD in speech pathology. And it was the best decision I've ever made in my life.
Love that. I love how full circle too, because I saw the otolaryngology stuff that you've been a part of, and then with your dad. That's amazing.
Yeah, it is.
Okay,
actually, I got an award. My dad did his residency at University of Cincinnati, and then we moved all over the world for a while, came back to the Cincinnati area, and then I had an appointment in the University of Cincinnati College of Medicine in otolaryngology. So that was really pretty cool.
Oh my goodness, I love that. And Cincinnati Children's is too. Okay, Dr. Koch, do you want me to, I can tell you the question again because it's a three-parter. Okay, you got it.
I've got that. So I have a fairly unconventional journey into speech language pathology. At first, as a senior in high school, I thought I was going to study theater and stage design and costume design. But I very quickly learned that I was not going to be very successful in that. And I had an academic advisor tell me that. So at Michigan State. So I changed and I decided that I was going to go to law school. And so my whole first semester, I was preparing for law school, in the beginning stages of that. And I did not enjoy it at all. And during finals week, a girl that lived down the hall from me, she was studying for finals, I was studying for finals. And we jokingly said, I'm tired of studying this. You study for me and I'll study for you. And we swapped textbooks. And she was studying for Intro to Speech Language Pathology. And I started flipping through her book and I thought, this is amazing. I love this. And I immediately changed majors the very next semester. And then, after that year at Michigan State, I transferred to Central Michigan University for their program there. And then the rest is kind of history. But as far as my journey through my career, very early in graduate school, actually, I was so fortunate to do a clinical experience with Nancy Kaufman. And so that really ignited my passion for children who are highly unintelligible, children with, we didn't call it childhood apraxia of speech at the time. But that just really sparked my interest, and it's been a passion that I've kind of maintained ever since then. I was able to do part of my CF under some of her leadership as well. And then very early in my career, I found myself in a leadership role. And in hindsight, probably much too early, to be honest. But so that just kind of continued to grow as well. But the other part of my professional journey really was sparked when I was in graduate school. One of my professors said, "You really need to get your doctoral degree sometime and teach at a university." And so I approached my clinical career with the idea that I wanted to gain as much clinical experience as I could to inform my teaching. And then when the timing was right, in 2006, I started my doctoral program, and in 2009 finished that. And I've been in higher ed for 20 years now. That's a little bit crazy to think about, but and they had various leadership roles as well with 3 different university programs. But have always maintained my teaching interests in the area of speech sound disorders broadly within childhood apraxia of speech, and autism as well. In my clinical career, I primarily worked in early intervention. So I worked with lots of families in that very delicate time period of seeking a diagnosis for autism. So that kind of rounds out that journey as far as the clinical part and my more academic part in higher ed.
I love that. And I was very fortunate to have you as a student. It looks like you have another student on here as well. So
I do. I had a student say hi. That's neat.
Well, what a fun story that is about switching textbooks. We talk about recruiting people to the field. Maybe that's all we need to do.
Right. Sending textbooks around.
Did she end up doing law? Like, that would be an amazing trade-off.
No, she finished in speech language pathology as well.
Well, that's great. All right, well, let's dive into the area of speech sound disorders. How has the treatment and evaluation of speech sound disorders evolved through the years, and especially throughout your careers? And Dr. Koch, would you like to answer first?
Oh, goodness, sure. Well, some of the things that I've seen in the course of my career, as far as in speech sound disorders, the whole idea of the phonological approaches was really kind of new at the beginning of my career. Barbara Hodson's cycles approach came out in the late 80s, and I was so excited to implement her strategies. So that whole idea of differential diagnosis and making a determination, is this an articulation disorder? Is this a phonological disorder? I've continued to see that grow over the years. I think that as part of that phonology area, the idea of minimal pairs and how that has evolved to then minimal oppositions and multiple oppositions and maximal oppositions, and then the complexity approaches and looking at those implicational universals and the sonority sequencing principles, and looking at how important those elements are in treating a child who is highly unintelligible. It's not just teach them how to make their sounds and they're going to be fine. It's much more complex than that. And it's been fun to see that all of those other elements become more prominent in our assessment approaches and in our intervention approaches.
Thank you.
Mm-hmm.
And Dr. Kummer, how about you? Mm-hmm. How have things evolved and changed throughout your career?
Well, when I was in college, I took a class called articulation disorders, because that's what we called it back then. And my professor was Robert Meleisen, who had done a lot of research at that particular time with somebody with the last name Snow. And so we spent the entire semester talking about his research and the research of others. So the last day of class, he said, any questions? And I raised my question or raised my hand to ask a question. And I said to him, I said, so when do we learn how to do speech therapy? And he looked at me and he said, he said, well, explain that. And I said, well, like, how do you correct individual sounds? And he said, well, Anne, if I told you the secrets of learning how to produce different sounds, you wouldn't be able to figure it out yourself. You don't need a cookbook. You have to analyze the speech and figure it out yourself. I will never forget that as long as I live, because I never had another course that taught me how to teach placement. And to this day, I don't know that that's taught very much. And so I spent a good part of my career trying to figure it out. And after a while, I figured out strategies that work really well, and I figured out strategies that don't work at all. The problem with that is that all those years ago, I didn't do a good job for my patients like I would now, because I know so much more now than I did then. So I really think a cookbook is really important of strategies to achieve placement. And another thing that's really important that for people to understand is that it doesn't usually matter what the child is doing wrong, that your strategy is always going to be how to produce it correctly, right? So you could have a lateral lisp or a frontal lisp or a pharyngeal fricative for S's. The strategy to correct it is all going to be the same. And so, that is something that I think has changed, or I hope has changed. The other thing is I worked in the public schools for 3 years, and I would be able to get the child to be able to produce the sound, but I'd see the same child over and over again, sometimes all 3 years. They could produce the sound, but they never used the sound. And I couldn't figure out why that was. And one of the reasons that I know now that I didn't know then is that we didn't learn about motor learning and motor memory theory. And so what was happening is I would send home homework, but the parents never did that. And then during parent-teacher night, they would go talk to the parents, but they'd never come to talk to me. And so what was happening is I was seeing these kids maybe 2 times a week, and they were practicing with me, but they never did the practice anytime other than that in therapy. And so it was no surprise, really, in retrospect, that these kids didn't learn to carry those sounds over into connected speech. So I guess, those are some of the things that I've learned, and I think is different now. I think people recognize some of those things more now than they did when I first started in my career.
Thank you.
That. Yeah, and I think that principle of motor learning is something that we use. So now I'm using it with really every kiddo that I see. Just that repetition is so important. And so I think we all, though, do have those cases that we think about, like, I wish I would have done this. But yes, you hit on all that lovely stuff. So, okay, well, Dr. Kummer, I'm going to have you answer first this time. Is there any, and pick 1 or 2, any pivotal research that you can think of that has significantly impacted your area of studies? I know this is
yes. There are a couple that come to mind, and the one we just touched on, motor learning and motor memory. I've got a couple of references that I put on my reference list about this. I think this is so important because what we were never taught is that there are really 2 stages of motor learning. One is you teach a skill, the child tries to do it, there's a trial and error period, and then we give feedback. And that's what we do in speech therapy when we're trying to teach how to produce a different sound. We give them instructions, they try, they may do it right, we give them feedback on that. They do it wrong, we give them feedback on that. But once they can produce the sound, then we need to think about motor memory. And with motor memory, the key part of that is practice. And it's a lot of practice. And, I didn't really understand that before, but you know what? We have often done a lot of practice in speech therapy, but what we've forgotten is that 2 times a week or 1 time a week is not enough. That we need to make sure that kids are practicing a lot, not just in the therapy session, but at home. And I've seen a new word in our literature, and that is dose, practice dose. And I really love this because it's defined differently, but basically the concept is the same. And my definition is the dose is the number of correct responses in a practice session, whether it's in therapy or at home. And we all know that the higher the dose, the faster the practice will be. So when parents say, how many sessions is it going to take? How many repetitions is it going to take? I don't know how many to correct the sound, but what I do know is more is better. And therefore, drill is really important, and practice at home is really important. So we need to train families to be able to practice at home. And I know that's hard. I was a working mom, and if you told me I had to practice an hour a day or an hour once a week with my child, I'd be totally overwhelmed. But we know that short yet frequent practice sessions are important. So I would say to families, you know what? If you practice with your child for 30 seconds, that counts as a practice session, but do it 30 seconds 4, 5, or 6 times a day. So that relates to distributed practice, which is another thing in motor learning theory. And then the frequency too. We can't see the child every day, but the parent can. And so I think that, that research has really impacted me. Another thing is I'm really into ankyloglossia by default because I wrote an article about it in the 90s. And I'm really passionate about this area. There's so much misinformation about ankyloglossia. And the truth of the matter is ankyloglossia rarely causes speech problems because the tongue doesn't have to elevate that much to produce an L. And in fact, you can put the tongue down against your bottom teeth and produce the L with the dorsum, and it sounds the same. The tongue doesn't have to go out very far except for TH, but you can actually produce that with the tongue tip against the bottom incisors. Unfortunately, like I'm reviewing an article right now where they're making a statement that ankyloglossia causes speech problems. And it's just pervasive. Yet people don't realize, they don't look at what's really important. So the American Academy of Otolaryngology Head, Neck, and Surgery did a consensus report in 2020, and they said anterior ankylossia is a potential contributor to infant feeding problems, but does not typically affect speech. And a significant number of children are having unnecessary surgeries on the lingual frenulum. And then there was another article by AHRQ, it's the Agency for Healthcare Research and Quality. Basically, they found the same thing. It doesn't affect speech. And yet there's a lot of stuff coming out. So that really bothers me. And then the third, and then I'll stop, is a myofunctional therapy for speech sound disorders. A lot of people think that that's appropriate, and it's not. And the reason is because most speech sound disorders in children are due to abnormal placement, not weak muscle strength. And strengthening the muscles isn't going to change the placement. Now, some kids have hypotonia and dysarthria, and maybe muscle therapy is appropriate for those, but it's really not appropriate for speech sound disorders. And in fact, there are some studies. One just came out in the Journal of Orofacial Myology and Myofunctional Therapy. So out of their journal, they reviewed 13 studies, and they found that myofunctional therapy alone or in combination with articulation therapy was not more effective than articulation therapy alone. And that high quality studies showed no speech improvements directly attributed to oral motor exercises, and lower quality studies yield mixed results, but lacked the methodology rigor. So, I think that that's really important, that kind of literature. And then related to that, oral motor exercises. This one drives me crazy. So there's some studies by Greg Loft and Dennis Rossello and Linda Vellino, and all of them have shown that non-speech oral motor exercises, including myofunctional exercises, do not improve speech production. And it's because these exercises really don't mimic the actual speech movements. They're unrelated, so there's no transfer of skills. So therefore, articulation therapy or speech sound therapy is the gold standard, not these exercises. So those are the ones that I think have really been important study areas in my career.
Thank you for all
and that's a long answer, but that's a big question.
Okay, Dr. Koch, any pivotal research?
Sure, and I will say I echo Dr. Kummer's sentiments about oral motor exercises and myofunctional therapy and ankle glossia. I talk to my students a lot about principles of motor learning and the studies by Greg Loft, especially about oral motor exercises and how we only use about 10% of the strength capacity of the tongue anyways to produce speech. We don't need to strengthen the articulator, the muscles that move our articulators. And yet still my students come back saying, well, my supervisor talked to me about they're doing oral motor exercises. And I just think, so I try to equip my students with how to have those conversations respectfully to maybe generate a different perspective in how therapy is being conducted. But I would also add that the idea of the phonological approaches and the contrast approaches, the multiple oppositions, maximal oppositions, minimal oppositions, really helps build the foundation for why children need to produce their sounds accurately. So for the most part, when we've got children who are severely unintelligible and have a severe speech sound disorder, there's a combination of, do they know how to produce the sounds accurately? So we're still teaching them how to produce new sounds or sounds that are being produced inaccurately. But we also have to teach them why, that when they use those sounds appropriately, they convey the message that they intend to convey. So that the research by Judy Garrett that started honestly in the 80s, it's a perfect example of how it takes us about 17 to 20 years from research to practice. That is beginning to filter into clinical practice for target selection and why do we choose specific targets, and being a little bit more intentional for how we choose targets, whether it's establishing those contrasts, whether it is looking at a facilitative context that helps build on the principles of co-articulation and assimilation to help kids produce their accurate speech sounds, especially R. Those are some areas of pivotal research that I think is really beginning to filter into clinical practice in very positive ways. And then some that I feel we need to work on eliminating some of those processes and those thoughts and those recommendations and the ways that people are conducting therapy.
Thank you both for sharing. Okay, what further research would you like to see developed to advance this area? Dr. Koch, do you want to go first?
Sure. I would love to see more research on the principles of motor learning and their role in speech sound intervention. I would love to see more research on complexity and the selection of more complex targets and the impact on that developing sound system. I would love to see more research on dosage. We don't have a lot of good intervention research to help us with making good estimates about prognosis, making good estimates about time in therapy. I think that Dr. Kummer referenced earlier, how many sessions will it take? We don't have good information to support those kinds of answers. And I think it would help us with the financial aspect of intervention programs to have better answers for that. So I would love to see good, rigorous intervention research specifically about dosage. I would also love to see more information about prevention in the area of speech sound disorders. We still seem to be in a model of deficit intervention and identifying the deficits and developing therapy to address those deficits. And yet we know the benefits of prevention, and we're good at prevention in other areas of clinical practice, but I don't see that being implemented yet in the area of speech sound disorders. And I would dearly love to see that, so that we don't have sixth graders working on their R sound still.
I think you're muted.
I was coughing, so I muted myself.
Oh.
You know, it snowed here in Cincinnati today, so I don't know if there's having a little allergy or something with the change of weather. Speaking of prevention, can you share maybe, you know, just a couple elements of prevention that you would like to see researched?
For me, or
yes, for you.
well, I think that I think it's Teresa Farnham actually said something that to the effect of, if all children are learning all sounds of their sound system from the time they start babbling to the time that they start speaking, then shouldn't it be developmentally appropriate to work on any sound at any age? And I think that's a very powerful statement. That, you know, we don't say, oh, we can't model R yet because they're only 2. We're continually providing that input of all of the speech sounds of our language at all ages. And so I would love to see that element of intervention looked at a little bit more closely. And if there is capacity, if the child is stimulable for a sound, that maybe we don't have a developmental expectation for them to have mastered that sound, why can't we go ahead and address that in therapy? And then what that impact could be on academic achievement and literacy.
Mm-hmm. Mm-hmm. And Dr. Kummer, how about you? What would you like to see?
Well, I agree with everything that Dr. Koch talked about, and I'll even take it one step further and go not beyond prevention, but research into causation, because that helps you to learn what you need to do to prevent. Many years ago, I think it was in the 90s, I reviewed a book on prevention of communication disorders, and to save my life, I can't remember the author, but it was really fascinating. And one of the things that he was talking about was the environment, things in the environment that affect the brain. This was way back when we weren't really thinking about this. So I'd like to see more research on what actually causes these disorders and what we can do to prevent them. The other thing that I would like to see is the use of AI to be able to develop online treatment plans for patients where they can actually get online. I mean, I know that there are some programs out there, but I think they can be further developed. I think the most important role of a speech pathologist is to do the diagnosis. That's the hardest part. That's what takes most skill. But once you have the diagnosis, then if we had AI to help us to plan individual treatment plans for patients based on that diagnosis that they can do on their phone, on their computer, they can do it during lunch, they can do it throughout the day, where they're getting a lot of practice that doesn't require an adult, a parent, or a speech pathologist to supervise, that they're getting the feedback as they should. You know, another thing is, speaking of feedback, I don't know that there's a lot of research on this because I haven't really looked, but one thing I learned in the middle of my career is that some kids don't carry over the sound because they don't realize when they're producing the sound incorrectly. They don't self-monitor. And so I started using sensory awareness techniques. So I start out with auditory awareness, tactile awareness, and visual awareness. And just to give you an example, like a glottal stop, you produce it with a instead of like buy baby a bib, you might hear or with kids who have cleft palates, well, you know what? If they don't realize what they're doing wrong, it's hard for them to learn to do it right. And so in terms of tactile kinesthetic feedback, I have the child hold their neck and they can feel the and they can feel the It's a very different feeling. I have them look in the mirror and you can see the jerk, is what we call it, with a glottal stop, and when it's not there. And then I very simply have a happy face and a sad face, and I say to the child, now it's your turn to be the teacher and I'm going to be the kid. So I'm going to say boat. And if I said that correctly, you touch the happy face. If I say oat, you touch the sad face. Well, the thing about it is, it's not auditory discrimination training, it's auditory awareness training. So what I want them to do is I want them to pay attention to their own speech. And I want them to double check how they're doing, whether they're doing it correctly or not correctly. So by doing this sensory awareness, and it usually doesn't take long. I mean, I do this maybe in 1 or 2 sessions max, but it gives them tools to be able to self-correct. So, more research in that and how that can be done.
Mm-hmm.
Love that. I think that's so important too. Even, I've had a few clinical students, and so knowing also how to train someone out of grad school or in grad school, what is it the best kind of feedback for our clients too, because we need a multimodality of different types of, cues. So I think that that's perfect.
Feedback or awareness is really important. Like if you try to learn another language, and like I'm trying to learn French, for example, I'm not, but if I was trying to learn French, I would say the French word the way I think it's said. And then the other person says, well, no, that's not right, but I can't hear the difference. It seems right to me, but it's not right to a native speaker. But I think that with kids, it's the same type of thing. If they're using T's for K's, that sounds normal to them.
Right.
They don't think that's abnormal. And so what we need to do is we need to teach them to pay attention to how other people produce that sound and how they're producing that sound.
And I love how you incorporated AI, because that's such a big thing right now. And so
Yeah.
it's going to be, as we evolve, it's going to be super important to have it evolve in a very kind of, evidence-based practice way too. Like
Yes.
you said, it could really, cut down our time on planning. And so hopefully in the positive realm of using AI. Thank you. These were so insightful. Okay. How about, and Dr. Kummer, I'm going to have you answer this first.
Okay.
What would be the most significant change that you have seen during your career?
Okay.
It could be philosophy or theory, debunked.
Well, I'm going to talk about something not just speech therapy, but models of therapy. So when I first came to Cincinnati Children's, we would see kids twice a week for half an hour. And this was back in the 70s when most mothers didn't work outside the home. So they were able to come and bring their kids twice a week for half an hour. And then we found that, you know what? They weren't able to do that. So we changed our model and we would do 1 hour sessions once a week because it was much more convenient for the family. It was easier to schedule in some ways. And it was less costly for the family because they had to drive to and from, et cetera. But the problem with the hour sessions was after a half hour, that child's done. They don't want to continue. And so the value of that second half hour was not as great as it was with the first half hour. So what we did is for the other thing is that we used to get 30 sessions per year covered by insurance at least. And then it got to the point where we were getting 20 sessions per year. And then it was like 15 sessions. So we totally changed our model of providing services. So what we did is we went to block therapy. And so with block therapy, what we would do is maybe schedule the child for 4 sessions every week for 4 sessions. During those 4 sessions, we would teach the child the skill and teach the parent how to practice with them at home. And then what we would do is then we would skip a month and then bring them back the following month to see how they're doing. And if they still needed help on that particular, whatever it was they were working on, we would go back to that. But a lot of times, by the time we reached the second month, we were ready to go on to different goals. And so what ended up happening was we were seeing kids less, but we were making more progress with these kids because we were utilizing the family members to do the practice, and we were only using the therapy sessions to teach a skill. And therefore, it costs less. We're using less sessions. It was more convenient for the family, and they were making more progress. And we revised that schedule based on the child. So there were some kids where maybe we would put them in 3 months of therapy, and then there would be 1 month off. Or it might be 6 weeks of therapy and 6 weeks off. So it was all based on what that particular child needed and how fast they were progressing. If they were progressing quickly, we would have the sessions closer to each other, the blocks closer. If they were progressing slowly, we would have the parents practice more before we brought them back in to teach a new skill.
I love that because you get really good buy-in too with.
Oh my gosh. Well, the other thing is if you schedule, we used to schedule kids, once a week or twice a week through infinity. The problem with that, if there's a birthday party that comes up, they're going to cancel that appointment,
Right.
And we don't find that with this block therapy because they know that, it's only going to be 4 sessions or it's only going to be 6 sessions. So you need to commit to that.
Mm-hmm.
No cancellations. And it's amazing. It was really a much better situation for us because we were losing money through cancellations and no-shows, and they were making more progress. So it was a real win-win.
Yeah, I love that. Okay, Dr. Koch.
Well, I just want to share something that it kind of goes along with what Dr. Kummer was saying. In my previous institution, I ran a pirate camp in the summer for the kids who need work on their R sounds.
Oh, yeah.
So we scheduled these students for 1 hour of therapy, 4 days in a row. So they got a block. It was intensive. It was one-on-one. But the number of children who made the progress they needed to make to come off of their IEPs in a very short time period was just incredible. But again, it was that intensity that they got, and in addition to one-on-one. Unfortunately, with our school models, it's a rare thing for a child to have one-on-one speech therapy in our school setting. So
Yeah.
I am very much an advocate for that intensive therapy like that. Changes that I've seen broadly across the models of service provision, and I was an early intervention therapist primarily. The whole movement from the clinician being the person delivering intervention to the parent coaching model. And recognizing the important role that parents have, much the same as Dr. Kummer was talking about, that we train the skill, but the parents help us establish that skill, and help the child retain that skill. And that very much is the same in early intervention as well. So parents as partners in intervention with us has been a big change. I started early intervention with the F-ASHA Infant Project in 1990. So, when we were the primary interventionists, all the disciplines provided therapy, and we've evolved to primary providers, but a parent coaching model. I would say that the kind of the evolution of treating speech sound disorders as an articulation disorder, and looking more broadly at a phonological disorder. And then, more recently considering that a phonological disorder may not be linguistically based, but motor mediated, and that the simplification patterns may not be linguistic, but maybe more motor influenced then. And I love that inquiry about really considering that perspective. So that's been fun to begin thinking about more recently.
Mm-hmm.
Thank you.
Mm-hmm.
All right, so lots of changes. We've talked about dosage, intervention, prevention.
Intensity.
Say that again, Megan.
Intensity too.
Yes, yes. Intensity, block scheduling, articulation disorders versus phonological disorders, and linguistic versus motor. We've talked about research, but what further changes would you like to see in our field in this area? Anything else?
Who are you asking?
Oh, Dr. Koch, sorry.
Oh goodness. I'll let Dr. Kummer go first on this one. I want to ponder this one a little more.
Well, you know what? I think that's a hard question to answer, to be honest. One thing that I think is a problem in the area of speech language pathology is that we have become so broad in terms of the scope of practice. And it's changed dramatically in my career. And the problem is, the broader the scope of practice, the less likely you're going to be proficient in any one area of practice. At Cincinnati Children's, I remember when I was first there and I would see a teenager with head trauma and then somebody who stuttered and then cleft palate and then cerebral palsy. You can't be good at everything. And so I think we need to focus more on specialization. And I think also that the type of caseload that you have in the schools is you have a lot of language and learning issues. So, if you are going to be working in schools, that should be the focus. If you're going to work in a medical center, then you're going to do kids with head trauma, feeding and swallowing disorders, cleft lip and palate, etc. So I just really feel like we need to specialize more and then have recognition for specialty training. That way we have a group of experts, not just a group of generalists that are providing services.
Mm. And there are various different, recognitions and certifications. Are you saying that ASHA, or would you like to see ASHA have more certifications?
Yeah, I think that they should, because there aren't enough. For instance, craniofacial anomalies, we recommend surgery.
Right.
You got to be good at that, because if you don't know what you're doing, some kids are going to get surgeries that shouldn't, and some kids aren't going to get the surgeries that they should. And that's just one example. But I think that there needs to be some recognition for specialization and expertise in certain areas, but also at the graduate level. I think that we need to allow people to specialize in what area that they think they're going to go in, whether it's going to be school-based and language learning issues or medical-based type of issues. I think that that's really important.
Thank you.
Yeah,
And Dr. Koch, would you like to add anything?
Sure. I think that from a program perspective, when you think about 4 to 6 semesters and trying to prepare someone for entry level, and which is the expectation is across the entire scope of practice, it's impossible.
Yeah.
Students work very hard to learn as much as they can in that time period, but our scope of practice keeps getting bigger. We keep learning more about the things that we're working with, the language literacy connection, and that's broadened our caseloads. I think some of the things that I would like to see change or be different, I would love to see speech language pathologists be reimbursed for and be compensated for the training and skills and expertise that they bring to the clients that they work with. With what we work with students in schools, we're helping them access their education. We're helping them to succeed academically. And yet the pay scale for school-based speech language pathologists is terrible. The workload and caseload requirements and the documentation requirements, it's making a career as a speech language pathologist, especially in the schools, less and less appealing and less attractive to the younger generation. And those caseloads aren't getting smaller, they're getting bigger. So we need more speech language pathologists in the schools. So those are some of the other practice-related things that I would love to see change. One of the things I've enjoyed in my career is the flexibility to move from settings and populations. But part of that came from the idea of being a lifelong learner and some of the training that didn't rely just on what I got from my graduate program. So I don't think we need to train for the broad scope of practice in our master's programs, but that to recognize that additional professional development equally prepares us for different populations and different settings, and that people could still have that flexibility without all of that trying to be shoehorned into a master's program.
That's a good
I
point.
agree.
So, not to put you on the spot and name anything specific, but do you think there are certain courses that could be eliminated as requirements and maybe have more flexibility within graduate programs? Or
that's a tough one, and in the programs that I've been with, those are ongoing conversations. We've got low incidence disorders. Are those the classes that we reduce? But you're going to have an advocate for those courses. No, that's important too. So I think all of the parts of our scope of practice are important. And I don't know the answer to that as far as do we narrow the focus of our master's programs, or do we allow students to choose their path, the coursework and their areas that they want to, I can't say specialize in yet because they're just new grads, but the areas that they focus on during their master's program. Is that one way to allow that flexibility? Programs still offer the whole range of courses, but students then choose the areas of interest, perhaps. I don't know. There's drawbacks to that too, from a financial aspect, from a university perspective.
That's true. And the cost of graduate school is a significant investment.
Right. If 2 students are interested in fluency, does the university support you still offering that course? It's not likely. So it's a difficult problem to solve, but the conversations need to continue.
Dr. Kummer, do you have thoughts on this topic?
Well, I think, I knew that I wanted to specialize in the medical aspect, but then I ended up working in the public schools for 3 years. So it is really tough. I think the student should be able to choose if they have strong feelings one way or the other. But I just think it's a real problem because we are too broad as a profession. I guess back in the day, you had to be a speech pathologist and an audiologist. And now you don't have to do that because that's so different. Even though it's all communication, it's really different. And so maybe we need to recognize that there are some differences in speech pathology as well.
Yeah. Well, and I'll use this example. When I was in graduate school, dysphagia was not part of our curriculum. Did not have a course in dysphagia. Fast forward to later in my career, and I was on the feeding team at a pediatric hospital. So, you can gain that knowledge, you can gain those skills and that expertise outside of a traditional master's program, and be able to do that. And that's an area that has really grown in our area as well as feeding and swallowing.
Which again, the focus on lifelong learning, continuing education.
Yes.
All right. Well, I think we have time really quickly. Are there any, you've had such amazing careers and have made so many contributions. When you reflect on your work and your continued work, are there any cases that have been particularly memorable for you that you'd like to share? And either of you can go first.
Well, I can go.
Okay.
So my first year working at Cincinnati Children's, I saw a little girl. She was 7 years old, And she had a history of cleft palate. The palate was repaired. She ended up having secondary surgery. And then I'm seeing her for therapy after that for a few articulation errors. And one of her errors was NG for L. So instead of look at the lady, you would hear look at the lady. And so we're sitting in front of a mirror, and I was pretty new as a speech pathologist. And I said to her, Jessica, this is what I want you to do. I want you to take your tongue tip and put it up here and do this, la. And she'd go, nah. And then I go, no, no, no. Watch your tongue, put your tongue tip up there. And then she'd go, nah. So what she was doing is co-articulating the L with an NG. And I just couldn't figure out what to do about that to get her, because she can't see it. She can't really feel it. She thinks that she's doing it right, going, nah. And so we're going back and forth, looking in front of the mirror. She's bored. I'm frustrated. Finally, she goes like this. Ah, she yawned and co-articulated the L with a yawn. I'm thinking that is brilliant, because when you yawn, the back of your tongue goes down and the velum goes up, the opposite of what happens when you do an NG. And so I learned that that's a great technique to use. So from then on, it was like we start out going, ah, lo, li. It was a perfect technique that I learned from Jessica. Okay, so fast forward quite a few years later, and I'm up on the inpatient floor, and I see Jessica there, not as a patient, but as a student. She was a student in speech pathology. And even better yet, a few years later, she joined our staff, and she's still there today.
Oh, wow.
Yeah, and I always tell her, I learned so much from her. I mean, that was a great technique for getting rid of an NG for an L.
What a great story. What a great case. Well, thank you, Jessica. Dr. Koch, how about you?
Well, I have a memorable client for a different reason, and I'll just share. So I was working at a Scottish Rite Clinic in St. Louis, Missouri, and I had this little boy, primarily severe speech sound disorder, suspected CAS. And we've been working on sounds, which nowadays I would approach his therapy very differently than I did at the time. But I was working on speech sound, accurate production of speech sounds, and my executive director was in her office, and she always loved to have the children come by and say hi to her. And this little guy, big brown eyes, I walk him in there, and she says, well, so and so, what did you get for Christmas? And he had an F substitution for this, and he said a big red truck. And I was horrified. I was so embarrassed, but it really firmed up my resolve to want to help children communicate the messages that they intend. And working with severely unintelligible children has always been my passion. And so from that, I think it just really confirmed the area of practice that I really enjoyed and had a passion for. And I still feel that passion today. And that's one of the things that I try to convey to my students. I want them to feel that same passion almost 37 years later that I did back then, even in that very memorable moment, but for a very different reason, to continue to have that passion for what they do as a speech language pathologist.
Oh, that's a great story. And your passion is contagious with your students, I'm sure. It's really, really, really great for both of you to share so much with us tonight. And we are getting close on time. I think, Megan, you have another question, but a little housekeeping before that, because we are almost at the hour. So if anyone needs to leave, we're going to spend 5 minutes taking our next question and a few questions from the chat. But if anyone needs to leave now, you can complete the course on your Speech Therapy PD account. Okay, go ahead, Megan.
Okay, last question, and this is a good one. Okay, and Dr. Koch will have you go first. Okay, what advice would you like to share to new or future clinicians? I'm sure you do this a lot as a professor, a clinical director.
I would say approach every day with curiosity and wonder and excitement and enthusiasm. Not every day is going to be wonderful. Not every session is going to go the way you plan. But when things don't work, think about it from, okay, what can I do differently? What did I learn from that? And what can I do differently? If every day is a learning experience, you don't ever lose that wonder, that excitement for what you're going to encounter during the day. And it carries you from one day to the next. It carries you through those difficult times. It carries you through those days when you can't imagine how you're ever going to get all that documentation done. So that keeping that wonder and that curiosity fresh every day, I think is helpful and healthy.
I love that. Lifelong learner. Thank you so much, Dr. Kummer. Any advice?
I think that was a wonderful thing, a wonderful bit of advice. Mine is going to be more specific, and that is that I find that a lot of speech pathologists don't really know how speech sounds are produced. And I think I learned because I was not taught how to correct speech sounds. And so I think that what they need to do is experiment with sound production in your own mouth. And if the child is doing something wrong that you can't figure out what they're doing wrong, try to imitate it so you can figure out. I think this is really important because it shocks me that so many speech pathologists think that sibilant sounds, which are teeth sounds, are produced by the teeth. You know, if you just feel that in your mouth, you will realize that we call them lingual alveolar sounds for a reason, and that you don't need teeth to produce these sounds. The sound is produced between the tongue tip and the alveolar ridge. Similarly, and I think this is one of my pet peeves, is the R sound. So many people think the R is produced in the front of the mouth, and it's not. It's produced in the back of the mouth. Doesn't matter if the tongue is up or the tongue is down, because you've already produced it in the back of the mouth when you raise the sides against the gum ridges above your teeth, and you provide, or that results in a channel where sound goes through there. So that's why we call it a vowel, because we're just manipulating the resonance. And that the beginning R is when you drop that tongue or move it forward. But you know what? You have to feel that in your mouth. And it occurs to me that there's so many speech pathologists that never think to do that. And so my recommendation is to always try to figure out what they're doing wrong by imitating, and then learn about how speech sounds are made by feeling them in your own mouth.
Yeah, I love that. During pirate camp, that's one of the things that we do is I look at the child and I say, I'm going to try to make your R sound the way you do. I said, I'm not making fun of you, but I need to figure out what you're doing.
Yeah.
So I know how then to help you.
Exactly.
Exactly what needs to happen for all of our sounds, not just R.
Absolutely.
I love that. Thank you so much.
Excellent advice. Okay, we have just time for, do we have a couple questions, Megan?
We have more comments. Some people are kind of saying yes about, specializing instead of being so broad, which is good. We just had one. Jana said, I wonder why we aren't taught how speech sounds are produced. So I know we did a lot of that in our motor speech disorders class with Dr. Koch, but really kind of working through how to do that too. So I think it depends on, where you're going and what course you have, but you can always go and find these courses, Therapy PD of how to work on each sound and how you target them. So
Excellent. All right. Okay, a little housekeeping before we end here. A reminder that this episode is available for Point One ASHA CEU. And if you would like to get the continuing education credit, please go to your dashboard and complete all course modules on your Speech Therapy PD account. So thank you everyone for attending. Thank you, Dr. Kummer. Thank you, Dr. Koch. And thank you, Megan Whelan. And not only thank you for contributing to our episode tonight, but thank you for your contributions to our field. You are both legends, and we appreciate everything you have done, and we would like to recognize that.
Thank you.
Thank you
It's been
very
a pleasure.
Thank you. Okay, everyone, have a great night.
much. Right.